In the third example, I'd like to introduce the Alzheimer case. Before going to the case, I'd like to give a brief review of Alzheimer dementia. This figure shows a slow march of the, here's my point, slow march of the Alzheimer dementia. Alzheimer dementia develop very slowly. Brain pathology can be found decades before the clinical symptom seen in patient. The slow march starts from amyloid, beta plaques, and then tau, medicated neuron injury, and the brain structural changes, and then memory impairment, and finally daily functional deficit. It takes over 10 to 20 years in extreme case. The slow march, this slow march, due to this slow march, but 10 to 15% with cognitive impairment, mild cognitive impairment go on to develop dementia each year. The prior to stage of dementia, two stages of impaired cognition are frequently defined: subjective cognitive decline and mild cognitive impairment. Subjective cognitive decline is a stage of subjectively experienced impaired cognition, which is not supported by any neuropsychological testing. But mild cognitive impairment is supported by in-depth psychological, neuropsychological testing. In both stages, the individual can perform the instrumental activity of daily life, but they are high risk of developing dementia. If we can find more modifying treatment, such treatment should initiate before disease progress to clinical state with severe cognitive decline or impaired functioning and activity of daily living. Therefore, it is of importance to find valid biomarker that could identify people that have high risk of developing dementia. This figure shows the dynamic biomarker hypothesis, including EEG. This is the amyloid beta accumulation. This is the synaptic dysfunction. This is the tau medicated neural injury. And this is the brain structural changes. And this is the alpha power decrease. And this is the theta power increase. And this is the delta power increase. So basically, we can take advantage of the EEG methodology, while the use of various MRI and PET method and cerebrospinal fluid examination measuring concentration of amyloid beta, phosphorylated and total tau protein, as well as other protein, including inflammatory biomarker, have shown to be helpful in predicting a patient with MCI and SCD, subject cognitive decline. However, use of the PET scan and cerebrospinal fluid biomarker and very time-consuming and personal cost-consuming and very invasive, consequently not ideal for the use of the daily clinical practice in the except the specialized setting. Therefore, the biomarker are generally not used in primary care setting, and not all the countries, especially in a poor economy. And some doctors are reluctant to use invasive methods such as tapping the CSF fluid, cerebrospinal fluid. But EEG, on the other hand, very low cost and invasive, and simple examination that can be used most clinic and even in primary care setting, especially the automatic analyzing iSync brain method is applied, and quick dry EEG recording iSync wave. If you can apply both platform technology, and the EEG is very good option, and you can tracking this alpha or theta activity, for example. EEG is more substantial. EEG change is more substantial compared to the structural changes in the preclinical stage, and very user-friendly and affordable compared to the amyloid PET imaging or CSF tau monitoring. I'd like to show Alzheimer MCI case with iSync brain. This patient is the 76 years old female, complain of memory decline, basically. She diagnosed it as the Alzheimer's disease based on the amyloid PET, and shows cognitive decline and at the neuropsychological battery. The MMSE score is 27, delayed recall is 16 percentile, the recognition is good. So this is the retrieval failure, basically, not encoding failure. The progression of dementia has been delayed yet, but basically she complained her memory decline. Basically, the patient take the choline alpha-late medication. Her QEEG finding is excessive theta and central beta and frontal gamma rhythm, basically. We can see her EEG in the iSync brain. This is her EEG here. This is the raw data. Raw data is kind of clean recording. This is the clean data in the common average montage. There is a slow wave. We can easily see the theta wave, lot of theta wave. In this case, this is alpha and this is theta. We can easily identify the basically width of the alpha activity and theta activities is quite different. And there are a lot of theta activity, but alpha activity is still very active, and also kind of beta spindle activity is coming together with this kind of theta activity. This is a lot of theta activity and alpha activity, repeatedly shown like this, slow theta activity. And we can find the component like this. The 19 component in the order of the power. The first component is the pre-central generated activity, basically very slow theta activity coming from the central area, and also have the high frequency. There is a 2 peak here. And second activity is coming from the superior frontal generated anxiety. Basically, this is the anxiety power spectrum from central area. And alpha peak frequency coming from the back of the head. And another central theta and SMR activity. This is the SMR frequency band. The slow wave theta activity and SMR activity is coming together in the central area. This is also coming from the central area, but the projection of the central dipole to the posterior area, basically origin is the central area. She has the central slow wave and the SMR wave like this in the component 1 and component 4. combine this kind of SMR activity is kind of counterbalancing activity of this slow activity. This kind of slow activity combined with high frequency activity, we often call this kind of frequency coupling as the sometimes we can call this activity is the thalamocortical dysrhythmia in some cases. Basically, SMR is a kind of activity for delaying the cognitive decline in recent clinical study. She has this kind of self-generated SMR rhythm here to delay her memory decline, basically. This is the lingual-generated alpha activity. And the another slow wave activity coming from the precentral area. And another SMR activity here, and slow activity. This slow activity and SMR activity combine together to delay her cognitive decline. This is another pattern coming from the postcentral area. This is the temporal alpha activity. Temporal alpha activity is not good, but sometimes associated with memory decline here, especially in this left temporal area. And this is the frontal slow wave activity we can solve in the raw data. There are a lot of frontal theta activity. Now another pre-central generated slow activity here. We can see basically a lot of central theta and SMR coupling, and a lot of theta activity in the frontal, and a lot of temporal slow alpha activity. This is her EEG, can be associated with her memory decline. Basically, slow activity is higher, and the beta activities is also higher. Alpha is decreased, basically. In the relative power, theta is excessive, and SMR rhythm is counterbalancing this slowing activity in this case. And we can see in the frequency spectra, there is a slow wave activity, and the central area there is a lot of SMR activity excess. And we can also see in the relative pattern there are slow frequency excess especially in the theta band, in the central area. The beta SMR band is excessive. The alpha peak frequency is preserved at this point, and alpha peak frequency is remained 9.0 frequency, but the slow activity is coming from the frontal area and temporal area, and the slow theta and the beta excess is counterbalancing at the central area, basically. We can estimate, combine this kind of activity is especially central SMR excessive pattern in her cases is the counterbalancing activity for delaying the memory decline. And recently we can see this kind of clinical study, SMR enhancing and theta suppression neurofeedback training improve the cognitive performance. Recently published in the Aging Neuroscience in Frontiers journal. I'd like to briefly show the three different QEEG cases using independent component during cognitive decline trajectory from SCD to MCI to dementia. In cognitive disorder, the SCD, this is the case we saw, the mild SCD and the borderline between the SCD and MCI. This is the case we just reviewed. The first component is the very slow frequency activity, and basically combined with the alpha activity and the beta activity. This is the first component of the subjective cognitive decline in the beginning state, kind of self-memory complaint. If the SCD developed to the MCI, the first dominant component is the very slow alpha activity, for example, in this case. And this is the AD, Alzheimer dementia case. The first component is there is no alpha frequency in this case. So the 19 component, especially for eyes closed condition, first component is definitely posterior dominant alpha rhythm. But in the SCD, first component is posterior alpha with broad spectral bandwidth in this case, and alpha peak frequency is still around the 10 Hertz, and slow frequency and start to increase in the MCI. The alpha frequency band is quite narrowed and far below from the 10 Hertz adult normal frequency. In the AD case, there is no the first component is no longer alpha, but all slow component originating in this case the middle temporal gyrus. Component information is very useful for understanding QEEG profile. iSyncBrain MCI classifier can also predict early stage of Alzheimer dementia using multi-level ensemble machine learning classifier. We can classify the SCD, normal, and SCD, and MCI with amyloidopathy and Alzheimer dementia. We can classify this trajectory in the iSyncBrain MCI classifier. I'd like to briefly describe the thalamocortical dysrhythmia. In thalamocortical dysrhythmia is a model proposed to explain the divergent neurological disorder, basically characterized by the common oscillatory pattern, the resting state alpha activity is replaced by the cross frequency coupling of low frequency and high frequency oscillation. In their study, they identify brain area for the Parkinsonian disease and the pain and depression and tinnitus and various diseases. They found the specific thalamocortical dysrhythmia area in their study. The reason I describe this kind of thalamocortical dysrhythmia, in the Alzheimer trajectory, alpha decrease and slow wave zeta activity increase, and also the compensating beta activity is coming together. In the previous case, the mainly theta activity is coming with the SMR frequency, SMR rhythm. This kind of different frequency oscillation at the appear at the same time. We can see the Alzheimer developing trajectory. This is a basic hypothesis of thalamocortical dysarrhythmia, can be also applied in the Alzheimer developing trajectory. Basically, in the Alzheimer dementia, alpha is finally disappeared. Before developing Alzheimer dementia, theta and the beta activity is coming together, and that's kind of a very similar story, I think. The